Thank you very much, Jill, and thank you everybody for being here. I'm quite excited about these guidelines. Quite excited because they have entailed a lot of work. A lot of wonderful people have been involved. And I think a lot of education is in these guidelines, but we'll speak more about that later. So the...
Oh, it's not moving.
It's not moving. Thank you.
No worries.
The purpose of this webinar is to talk about the OPA guidelines for diagnosis and assessment of learning disabilities. And as I say, I'm quite...
How do we minimize that?
This side?
The
my view.
our views,
Our views.
so we can see the screen. There's slides. Sorry. Okay.
Okay, thank you. Yes, so the goal is to talk about the guidelines, and we hope that at the end of this, you'll come away with an understanding of the framework that psychologists use to carry out assessments in terms of what they look at, why they look at those kinds of things. We hope also that you learn about the process of psychological assessment and why we conduct these assessments, how we do it, why we do it, and some of the key questions we ask as we go through it. And that's the real strength of these guidelines. If you're an educator in the audience, I hope you come away with information to help you make a valid referral, and since you better understand what the kinds of things that we look at. And finally, learn about adaptations to assessments that are made for culturally and linguistically diverse students. And particularly, Judy will speak about that. I'd just like to speak that the guidelines were written not just for dyslexia, but for mathematics and written work. Many children have many of these things in combination. We don't use the terms dyslexia, dysgraphia, or dyscalculia. Nothing against these terms, but they're more medical in content. Some people feel that way. And many children have many of these things, as I said, including the various subtypes of dyslexia, of mathematics, and of writing. And we don't know at the beginning what these children have. So we don't have different criteria for different things, but we do explain all of this, we hope, in not necessarily in reports, but certainly in, well, yes, in different words in reports, but certainly in a one-to-one feedback situation. I want to speak for a minute about the historical context in Ontario. There is no consensus among psychology practitioners about criteria for assessment and diagnosis for LD across all ages, sectors, and populations. There are guidelines and for different ages. We tried to bring those together, and there are various models, and this is leading to confusion among the population on what is a learning disability. So I just want to review with you some of the documents that we looked at. In 1962, the Human Rights Code came into existence, and that was actually the legislation that governed universities and colleges in terms of what is necessary for a child to, or a young person to attain accommodations at universities. And what the criteria involved was an actual disability. So in 2001, the Ministry of Education funded a task force to look at a consensus definition of LD. And in the next year, the Learning Disability Association of Canada adopted that definition with some modifications. In around 2013, the DSM-5 was written and was revised. There was a DSM-4, there was a whole series, 3 before that, etc. This time it came up with a diagnosis called specific learning disorder, not disability. And within that document, it did state that A diagnosis of specific learning disorder might not identify a disability, and that further testing may be necessary for that. Many people felt that that may help with determining intervention. In 2016, the Association of Chief Psychologists with Ontario School Boards also came out with guidelines for diagnosing learning disabilities. And these mostly considered the LDAO definition and followed that with some differences. In around 2014, the Ontario Ministry of Education reconsidered its criteria for identification of learning disabilities. And this was identification, not diagnosis. Policy and Procedure Manual number 8, memo, Policy and Procedure Memo number 8. So it came up with, first of all, I'd like to say that it really looked at identification rather than diagnosis, but it was a document, I think, that helped guide our thinking. So, and I want to say this because of a focus in that document on intervention without identification. And I think that's a bit new to some people. The first thing the major thing that it said at the beginning was around identification. That school boards are required to implement procedures for early and ongoing identification of the learning abilities and needs of the students. Secondly, it focused on program planning, and it did say that it talked about the fact that program planning and use of special education services could happen both for students who had been identified as exceptional in an IPRC and for any other students who demonstrate difficulties in learning and who would benefit from special education programs and or services that are appropriate for students with learning disabilities. So in other words, again, IPRC is not necessary, and documentation was necessary, but that would be through the IEP, the Individual Education Plan. The next point pertains to the lack of need. There wasn't a need for a diagnosis. That what was necessary is the needs of individual students based on individual assessment of strengths and needs. The next point focused on who develops the IEP and when it's developed. So the school principal may decide to develop an IEP for a student who demonstrates difficulties in learning and who would be likely to benefit from a program or services. The point here being that the school principal it's usually delegated to the MART or resource teacher to write the IEP, but parental input is certainly expected and really helpful. In the IEP, certainly it would be helpful to include the recommendations from all sorts of professional reports, from the psychological professional report, any speech and language reports or whatever. So if educators do educational assessments and a psych assessment is not required for development of an IEP, why are psychological assessments important for some students? And what does the psychologist add to the education system? Well, let's look back at the objectives of psychological assessment. The first one is helping people to better understand the child. I guess it's important to take all the information that's collected to look at the child to better understand their profile of strengths and weaknesses so that we don't make assumptions about kids. We don't say, oh, they're just lazy or they're just not trying hard enough, they're not motivated. We want to look at their actual skills. Skills in the area of cognitive, academic, social, and emotional. We want to look at environmental factors in the homeschool community that may impede learning or actually help learning and emotional adjustment. And finally, diagnosis. Diagnosis being just a shorthand way of talking about the characteristics. So psychological assessments aren't just necessary for the identification. They're necessary for people to understand the child's strengths and needs. Psychological assessments also focus on recommendations for supporting the child, and that's very helpful. So helping the child in the classroom through learning strategies, executive functioning, remedial programs, and so forth. And then, of course, another particularly important role of the psychologist is communicating their understandings and recommendations to the child, parent, educators, and other health and mental health professionals. It's one of the things that often gets missed is talking to the child about their strengths and weaknesses, and that's particularly important because they're the ones that have to be motivated to carry out certain procedures that might be helpful for them. So going back a bit to the inconsistency in assessment and diagnosis. Parents have been confused. Some people are using DSM-5, some people are using LDAO, some people are talking about identification as diagnosis. Some boards have certain criteria, other boards don't have that criteria. So that causes disruptions in service when transitioning board to post-secondary. And there's often a duplication of service. There are reassessments and reassessments and reassessments, and that's unnecessary. So we brought a group of people together to work towards consensus. In November of 2016 until June of 18, this group of very knowledgeable people came together to bring consensus for best practice in the assessment of diagnosis of LD. They wanted to look at the diagnosis for many age groups, for populations, and in different settings. They wanted to bring it all together. So the guidelines were not just for children, but they were for adolescents and young folks and other folks as well. The sectors involved, the people that were there came from education, hospitals and clinics, post-secondary institutions, psychology training programs, and adult services. I think there were about 12 people. The Ontario Psychological Association and the Ontario Association of Psychological Associates were both involved in all these settings. And these were the people on the group. It was a group of excellent people, most of whom had had involvement in groups looking at the diagnosis of learning disabilities at other times. And they were able often to speak with their, what I would call constituents or peers, to get feedback about what the directions we were following. So the guidelines built on and updated current provincial discipline-based documents and regulations, looked at a great deal of research, evidence-based sources of information, included suggestions for best practice in the assessment process, and included merits of other definitions, both LDAO and DSM-5. And so the goal is for the guidelines to be adopted by practitioners across the provinces. Private practice folks, folks who use the DSM-5, school folks who tended before to use the LDAO, to come to a more of a whole view of the child and to provide information about disability. So the cross-sectoral psychology working group end product were these guidelines that you have on that Jill had mentioned that have been sent to you, and they're also here. A link is also here. They were adopted by the Ontario Psychological Association. They were adopted by the LDAO, and they became called the OPA guidelines, even though initially we were the cross-sectoral group. So our hope is that, again, these will be adopted by practitioners across Ontario, and we are currently making plans to speak to various groups in various communities. So let me go ahead with the OPA guidelines. They included both the consensus statement, which really were diagnostic criteria, And the real beauty of this is that it also included supporting documents that talked about steps for assessment and diagnosis, which I will speak about. And this involved key questions that researchers, that clinicians should look at. The purpose being to sort of educate the community and bring us all together. There were a number of frequently asked questions that were added, and Judy will mostly talk about these questions. This is a living document, and we are continuing to add frequently asked questions as we hear them to this guideline. So let me talk about the criteria for a minute. They were firstly, the history of academic functioning at a level below that typically expected for individuals of the same chronological age, or needing excessive time and support to develop and maintain typical levels of academic functioning. The second one was below average academic achievement on standardized testing in at least one of reading, writing, and math. And these, this emphasis on academic functioning very much reflected DSM-5. The third criteria was evidence that the difficulties in reading, writing, or math was logically related to deficits in psychological processes such as phonological awareness, executive functioning, all those things that visual, spatial, and I won't go through all the others, but processes was in there. Criterion D was at least average abilities essential for thinking and reasoning. And as we go along, you'll note, and Judy will talk about the fact that those abilities need to be considered very, very carefully, and we look for the best estimate of cognitive ability. And finally, evidence that the difficulties in reading, writing, or math cannot be accounted primarily by other factors. So let me go through the steps, and I'll try to do that quite quickly. First of all, a thorough history and school review, meeting with the parents, meeting with other people, looking at previous test results, etc. Step 2, determining if there is a history of developmental health, educational, or other risk factors for LD and other learning disabilities. So history of exposure to teaching and response to specific interventions, and risk factors in young children, difficulties with foundational skills such as rhyming, counting, etc. Looking at the risk factors, even if a diagnosis can't be made because the child is very young. It's really important information to collect. Step 3, the academic achievement in individual academic achievement tests is at or below the 16th percentile. So basically, these guidelines are saying if there is no academic deficit, there is no learning disability. And that information really comes from research that we don't have time to go into tonight, but it's very important to get that point. So in the area of reading, some of the areas people might look at are word identification, pseudo-word reading, to look at phonemic awareness, fluency in reading individual words or text. And in terms of comprehension, literal or inferential reasoning in terms of the comprehension issue. Writing, looking at the different types, spelling, sentence structure, grammar, vocabulary, and then separate from that, ideation, organization of written text. Sometimes difficult to assess those kinds of things, but very, very important. Essay writing, that kind of thing. Math, both calculation and the word problem solving. Of course, the word problem solving perhaps having more linguistic weighting than the straight calculation, although then when you get into geometry and algebra, you're looking at more abstract reasoning. The psychological processes that are risk factors for the academic difficulties. The main point here is that processing deficits alone don't constitute a learning disability, that the academic achievement has to be below age expectation, as was mentioned before. And in older people, social interaction or occupational functioning is very important, can give you a key to processing deficits. Now, step 5, assessing abilities essential for thinking and reasoning. We had a lot of Discussion about the term thinking and reasoning. Basically, we're trying to get at abilities separate from processing, and that's not totally possible at all. But so there's a lot of planning and looking at scores and reasoning on our point. Thinking and reasoning is typically measured on standardized individual IQ tests. IQ tests being mostly IQ tests being a series of ability tests. And for many individuals with LD, the global scores are valid. Now, the professionals, the psychologists in the that are listening will understand global scores. Basically, it means all the abilities put together. So if you put all the abilities together, for many individuals with LD, this makes sense. For others, some of these global scores aren't valid, and you can look at that and sort that out yourselves, I think, as you go through. It's very important to do that. Because their processing deficits and poor reading may reduce scores. For example, vocabulary. If the child isn't reading, their vocabulary isn't going to be very good. And so processing really affects verbal scales. You might want to look at a nonverbal scale. You might even want to look at a nonverbal test. But all tests have some degree of language or cultural loading. And the second point involved that might not make sense to look at global scores is that the tests involve cultural components as well. So there's a bit of judgment involved here. All in all, psychologists should choose and interpret the test carefully, considering which tests, subtests, and scores are valid for the individual. Then there were 5 more steps. I won't go through them in detail because of time. Step 6 was ruling out other factors that could better explain the pattern of results. Step 7, assessing the social, emotional, behavioral strengths and difficulties that are common in individuals with LD, because we want the assessments to be fairly fulsome, looking at the whole child and looking at not only how it affects academics, but other areas as well. Step 8, developing the formulation and diagnostic statement in accordance with the above criteria. And step 9, recommendations. And notice here the term realistic supports and interventions that are required. So that, as one person asked about, why am I inundated with recommendations that I can't possibly ever implement? I think it's incumbent on us as professionals to choose the ones that are most realistic in the setting. And finally, communication is really important around the diagnosis and around the recommendations. So with that, I will turn it over to Judy.
Okay, so one of the questions you might ask yourself, if you are familiar with learning disabilities, is that many previous definitions talked about a discrepancy between IQ and achievement. And that was a key part of the definitions and criteria for many US states, and to some extent also in Canada. So our first frequently asked question that we address in the document has to do with this thorny discrepancy problem, because it's become very controversial. And notably, DSM-5 eliminated that criterion when it was central to DSM-4. So why did they do that? And basically because research showed that it didn't make any sense. One part of it is normal variability. So of all the hundreds of people who are watching, it's very likely that 90% of you have some discrepancy between some aspect of your IQ and some aspect of your achievement. And the higher your IQ, the more likely that's to occur. But you might have that and not have any challenges with achievement at all and not have a learning disability. So that's one reason. The second one is various psychometric problems, and the references to all this is at the end in your handout, but I'm going to just mention one that's really, to me, very telling, that when you in grade 3, over 30% of the students who had a significant discrepancy between their ability or IQ and achievement in grade 3 no longer had that in grade 5. So if it's did they lose their learning disability? Probably not. The other thing is very quantitative literature reviews also found many interesting things about this. First of all, people with that discrepancy had higher IQ scores. Well, that's not surprising. But they didn't overall have differences in reading, phonological processing, academic achievement, various internalizing and externalizing behavior problems. And so poor readers with a discrepancy or without, they didn't differ on any of those factors. So why would we include that? We know that discrepancy between IQ and achievement is also not a predictor of impairment in things like the workplace and adulthood. There's no differences between those with and without a discrepancy in the prognosis or probability for improvement in reading skills. Very telling is that there's no differences in brain function as measured on functional MRI, and twin studies are rather inconclusive about the heritability of it. So given all that, we decided that we would go with what is supported by research and eliminate that criterion for identifying learning disability. And of course, among that, one type of learning disability being dyslexia. I'm going to focus the rest of my time, or almost the rest of the time, on one of our frequently asked questions, which has to do with adaptations for students from culturally and linguistically diverse backgrounds. Part of the reason why I'm doing that is that we had as a basic principle that we needed to have our criteria and steps be applicable to all kids in this province or country for that matter. And secondly, that if it wasn't applicable, then perhaps there wasn't a good criterion or a good set of steps. And why was this important? And one aspect of it is the Section 15 of our Charter of Rights and Freedoms. Not only are we, like in the United States, saying that we're all equal before the law, but we also say that we're entitled to equal benefit. So that if we're looking at providing special ed or other kinds of help for kids, this has to be applicable across, including kids who have different race, national, or ethnic origin. It's right there in our laws of the country. Then we're looking at approximately a third of the kids in our province as coming from a culturally and linguistically diverse background that is not the standard sort of English and French kind of background. So there's 29.1% of our population is foreign born, 2.8% is Indigenous, but even that's bigger than the population of the province of Prince Edward Island. And the other thing we should note is that 69% of our immigrants between 2011 and 2016 came from Asia. And what is different from what some people hold as stereotypes, they're better educated than Canadian born. More go to post-secondary institutions, okay? So this is very important. So when their kids are having challenges, don't they need help? Okay, so I'm going to start with a case study, and I de-identify everybody, okay? So you have to know that I use a composite of various kids that I've worked with here. But the child who was referred to as, I'll call him Abdul, was referred when he was 11 and he was in grade 6. He immigrated from somewhere in Africa. They speak Arabic at home. He was a refugee who arrived in grade 2. So he'd been in Canada for almost 4 years, and he had also witnessed violence. In terms of his education, and the ASL teacher was the one who made the referral to our clinic here at OISE. He had no formal schooling before arrival in Canada, just odd, sporadic bits in various refugee camps. When he got here, he had 3 years of ESL, or English as a Second Language instruction, for an hour per day. But he was still functioning at a kindergarten level in reading and a grade 1 level in math. The ESL teacher was very concerned. And she referred him to OISE because at that time, the school board he was associated with wouldn't do assessments till you'd been in Canada for 5 years. I should mention that Abdul only knew 10 letters of the alphabet, and the only word he could read was his first name. He had mild attention difficulties, but he had acquired basic English conversational skills, and he was good at art, phys ed, and soccer. He lived with his mother, 2 older brothers who at the time were 13 and 20, an older sister who was 16, and his father was deceased. His siblings speak English and have made good progress in school, but the mother only has basic literacy and conversational skills. And interestingly enough, the main contact was the partner of the 20-year-old brother, and that kind of gets at how we have to adapt in terms of who we communicate with sometimes and spend time with. But she was born in Canada. She had the kind of cultural capital to be able to access resources, and that was important. So what I'd like you to think about as I talk is whether Abdul should be referred to a psychologist. What type of assessments should teachers do prior to that? And what are the issues involved in communicating with his mother? So I'm going to start with just a few definitions and abbreviations because they're there in the slide. So culturally and linguistically diverse is CLD. Depending on the slide, and some of my slides I took from elsewhere and I had to use I couldn't change what was on them. So ESL, English as a Second Language, ELL is an English language learner. It's basically the same thing. EL1 means English is your first language. L1 is first language, L2 is second language. So these are there and you can keep referring to them if you need to from your handout. So the question of when should we conduct psychological assessments with culturally and linguistically diverse individuals? Well, as I said before, there was some barriers in the school system to referring him to a psychologist because they said Abdul hadn't been here long enough. And there's this myth that's been out there that one shouldn't do these assessments for culturally and linguistically diverse individuals who study in their second language till they've been here for at least 5 years. When Jim Cummings stated this, this was in the mid-90s, before there were other kind of research. And he, in very good faith, wanted to prevent misdiagnosis as having an intellectual disability. However, we now know that there are ways of adapting our assessments for these individuals that are very important. So I'm going to give you I'm going to present some research, and there are some graphs in here to look at that show the development of various skills and why we can actually tease out, especially dyslexia, i.e. difficulty reading individual words in kids very early after coming to Canada. So my colleague Esther Geva did a longitudinal study in the Greater Toronto area, kids who, both first and second language students who had arrived in Canada sometime prior to grade 1, and she followed them through until the end of grade 6. What we see is that in terms of word recognition, and the red here is the second language learners, and the L1, the blue line, is the first language learners. And what you can see is that from grade 1 to grade 6, there is no difference. They are at the same level and they proceed at the same rate, on average, of course, because there's individual differences within the groups. The same is true with pseudo word decoding. So being able to read words that aren't real words but are phonetically accurate, okay? We see no difference between the groups. The little kind of curve at the end is not statistically significant. The same is true with phonological awareness or phonological processing. No differences. So all of the real key issues behind dyslexia, we see second language kids and first language kids progressing in exactly the same way. And that's really important. There is a but, however, and that's something we have to be aware. So when we look at reading comprehension, and this graph is showing the growth from grade 4 to grade 6, we have a gap still in grade 4 between, and these are the same kids, between the first and second language learners, with second language learners lagging in reading comprehension, even though they can read those words on the page. And that gap does not narrow at grade 6 at all. Okay, so that is really important. Similarly, when we look at vocabulary, and with vocabulary, and this is going from grades 1 to grade 6, we have a big gap between the second and first language learners in grade 1 in vocabulary. That makes a lot of sense. If your parents have been speaking to you in Swahili, you're not going to be acquiring English at home except from TV, maybe older siblings, but you're going to have a gap between that and other kids whose parents talk English to them at home, of course, in the English vocabulary. What happens is that that gap narrows by the end of grade 3, and it narrows again by the end of grade 6, but it still is there. And in fact, we have some evidence that it's taking 12, 15 years before that gap completely closes. So waiting 5 years isn't enough if that's all we were looking for. So we have to kind of work around that. So the question of how we assess oral language, I was told that that's a question that's been coming up quite a bit in people who are listening to these webinars. And one of the tests that Dr. Gava used for vocabulary was the Peabody picture vocabulary test, where you have 4 pictures. The examiner says a word, and the kid has, or adult for that matter, just has to point to the picture. And that's the one that we were using here. So you don't have to even be able to express yourself. But there are many other tests that look at phonological processing, the expressive vocabulary. People sometimes use the verbal and language sections of IQ and achievement tests. And both psychologists and speech and language pathologists will tend to use the CEL-5, or the Clinical Evaluation of Language Fundamentals. What I want to mention is that there are a lot of non-standardized kind of instruments or tasks, and I'm not going to go through them because of time, but Dr. Gava and I wrote a book on assessment, psychological assessment of culturally and linguistically diverse kids, published by Springer. And on the web link that I have on the slide, there are supplemental materials that has all of these tests and many other things. So anybody can access those supplemental materials free of charge. Obviously, the book has to be bought. I also see it as very important to look at and get a language sample from kids when doing an assessment. So whether you're a psychologist or a speech and language pathologist, I really want to see how they talk in context. And some of that is giving a picture or a story starter and having them tell a story orally, retelling a story for young kids using wordless picture books. Sometimes an interview about yourself, and with little kids, it can involve a pretend thing, that they're a pretend character, and you're really getting a sense of their language. The game 20 questions is useful because you're really getting at that whole issue of categorization and what their strategies are. So all of those kinds of things can be used. Now, in those supplementary materials is an oral language checklist, which teachers can use. They hear this kid talking all the time, and it gives them a sense of some of the things to look at and some of the things that we can use in trying to broaden their language and vocabulary. So that's really important, okay? So there's a lot of ways we can fill out language, which is, of course, a very key aspect of learning disabilities in general. And many kids with dyslexia do have associated language difficulties. So I mentioned earlier that I'd like you to think about, or that we would talk about, when do you refer to a psychologist, okay? And especially for immigrants in terms of time of arrival in Canada. So I have this grouped by if you arrive in kindergarten through grade 3 in the primary grades. And even before kindergarten, but sometimes kids aren't exposed to English before that if they come from homes where the parents don't speak English, right? And so to me, what we're having to do is in kindergarten, it may not even be necessary to provide English as a second language instruction from an ESL teacher, because the kids seem to pick it up from their peers and just being in the classroom. But after that, that's helpful. But if they aren't making progress in learning word level reading skills, the key core component of dyslexia, and we give them explicit instruction in that, and they still don't make progress, then it's time to refer to a psychologist to get a broader understanding, in my view, and in the view of many of us who work in this field. For kids in grades arriving around grade 4 and later, we have much less research evidence to guide us, but we do know that we need to provide intensive ESL instruction. We can expect, like their younger counterparts, that if the ESL teacher teaches reading decoding, they will catch up in that, and as well in math rather quickly. It's that their reading comprehension and written expression and vocabulary may still lag a little bit. And if it is just lagging a little bit, then I don't know that we need to refer to a psychologist. But if it's dramatically lagging, or if their reading decoding skills are lower, then again, we're needing a referral. Grades 9 to 12, it becomes even harder. The later kids arrive, the more challenges there are. So we're needing to provide intensive, and I'm writing level DSL intervention, and that our schools tend to do. So they'll have level A for kids who don't speak any English at all, level B for those with more skills, and so on. And I believe that ESL here tends to go up to level D. So that's really important. But they're needing, and in terms of learning to read in English, well, if they come from a place where they're speaking Spanish or Italian, they've been in school learning in those languages, the transfer to decoding skills is rather quick. On the other hand, Abdul came from a place where it was Arabic. So it's rather different because it's a different alphabet, a different orthography. So that makes a difference. But on the other hand, if they don't have a learning disability, they'll pick it up quickly if taught. Reduced course load is helpful for many of these kids. And in fact, we have evidence that if you give them an extra year to complete secondary school, many more of them will complete and go on to post-secondary education. We also know that having a peer or a university student mentor and tutor is really helpful. The data from the Pathways to Education program, which started in Regent Park and has moved into many of our low SES communities, is really striking in terms of high school completion and entry into post-secondary. But we've also seen in our clinic where we'll try to get an undergrad student to work with some of our teens who've arrived. And it helps with social integration, learning and acquisition of English, as well as tutoring in specific subjects. But if progress isn't being made, then we may need an assessment to figure out what else is going on. So one of the questions is, what is the educator's role? What does the classroom teacher, the ESL teacher, the principal, the special ed teacher, the school team as a whole do? Because they're needing to look at whether there's a history of academic impairment and other risk factors for LD. That would be part of your role. And to assess academic achievement in English. Sometimes in the kids' first language, although that becomes very complex. If you haven't studied in your first language for 4 or 5 years, then you're not going to be up to snuff in it. And so, and in our book, we have a whole section on when to do it and when not to that I can't get into here. So what are some of the ways we have to adapt the way we look at a history of academic impairment for these kids? One of the issues, as is the case for Abdul, is previous interrupted or inadequate schooling. So they may not have a foundation, let's say in math, that someone else does. Other immigrant kids may be ahead of us in that. So we have to be very careful in making that judgment. We have to look at whether the educational standards in the home country or indigenous community, for that matter, are different from our own home community, the community that the child is working in now. And so that makes it complicated to make a decision about that. Also, for some kids, report cards are just not available, or they're written in a language we don't understand. Not just, let's say, English versus Arabic, but we may not quite have get the code and know how to read it too. So some of the strategies I suggest is to, of course, examine in Canadian report cards to look at improvement over time. Comparing with siblings or others in the same context. That was really important with Abdul. His ESL teacher was working with a number of kids from the same context and saw him not making the progress the other kids were, as well as the siblings were. Ask whether there's been previous grade retention. In Ontario, we don't tend to have kids repeat grades, but in other community places they do. And if they do, and I'm not recommending it, the data suggests that that's not a good thing to do in general, but if they have, it's a sign that they were struggling in their initial language. Also interviewing the ESL teacher regarding the response to ESL instruction. So how do we know whether there are risk factors for learning disabilities and other kinds of learning difficulties? Well, we're often interviewing parents, but here are some issues that have emerged. Sometimes in some cultures, the parent who's not the primary caregiver comes to the interview. So in some cultures, it's the father's role to do that outside stuff, but it's not his role to do all the home stuff. And he doesn't really know the answer to some of the questions you ask, even if he's very educated. Some parents, and this was the case with Abdul's mother, they speak basic conversational English, but not well enough to communicate complex concepts. And that's a real difficult issue that sometimes emerges because the teachers and principals say, oh, well, they can make an appointment, they can get a cup of coffee, they can do all those things. We don't need an interpreter. That's actually not necessarily true. Parents might fear that psychologists might lead to the child being taken out of the home. That's I have seen in some of our northern indigenous communities where that's been so much of the history during the 60s scoop, residential schools and so on, that they really fear it. And of course, they don't know what the psychologist does in many cultural groups. Parent doesn't understand the importance of meetings, of coming to meetings, being punctual. They may work many hours and just be unable to do that. They may experience stigma, trauma, intergenerational trauma. So in terms of that, we need to look at getting an interpreter, even if the parent has basic conversational skills. A real big one is to take the time to achieve trust and explain confidentiality carefully. We need to listen to their story. We need to explain what a psychologist does. One of the things is we want to avoid a lot of direct questions, especially with the individuals who are refugees or who have experienced trauma, because they feel as if it's another interrogation sometimes, and really trying to be flexible. So what are some of the issues in assessing academic achievement? First, the standardized test scores are not valid because in many cases, the child is not part of that norming population. The standardized test also may show just what the individual can't do, not what they can do. So in Abdul's case, it didn't go down to finding out that he knew 10 letters of the alphabet and which ones they were, and that he could only read his name, okay? and they may not accommodate to the language and culture. So I am suggesting a whole pile of different informal methods. Word lists of commonly used words in the English language, such as the Dolch word list. For some kids, it may involve having games at first and playing sight word bingo, for example, or concentration and memory with those things. Using drawings to bring them out and culturally appropriate material. I'm going to focus on examining writing samples and error analysis and dynamic assessment. So when a teacher wants to look at kids, let's say reading, and is wanting to look at progress over time, fluency assessments that are 1-minute probes where there are several of them at each grade level, such as the DIBELS, can be very helpful. And I have the website on there. There are even tutorials on YouTube stuff that shows you how to do it. I'm going to focus on written language because I watched the Louisa Moat one, and she, of course, focused on reading. And there are many standardized tests that measure it. We want to look at handwriting and spelling, and also, of course, written expression. So all of our standardized tests do that. But there's also, to me, there's nothing like looking at a real piece of writing and analyzing what the child produces. And I do want to mention that when it comes to spelling, if you're not sure how to do an error analysis of it, Louisa Moats on her website has, and I have the link here, has a terrific scheme for doing that. So this is a paragraph that a child wrote in response to a picture. And this is a girl in grade 4, and she happens to have English as a second language. And when you look at this, you can see that she is really very good. You wouldn't even know that she lags behind, that she's an English language learner. She writes, once upon a time when cavemen and women lived, there existed a forbidden jungle where wild animals far greater than the tigers or lions live. And it goes on. And, you know, good sentence structure, good capitals, periods, advanced language, words like enormous, ferocious, even spelled correctly. You see that, you know you're not going to refer that kid for any kind of psychological assessment for a learning difficulty as soon as you see that piece of writing. You don't have to go any further. But then there is this girl. Also, same picture, grade 4, English language learner. So she writes, one day, and she means elephants, but it's ELELFINS, came to a village and people got scared, and I'm not totally sure what she's writing. She has good handwriting, or it's fine. She has capitals and periods, but what we can see is that she doesn't always have all of the sounds in a word. She doesn't have the silent E rule, the K instead of a C and K, but it's a common word. She has trouble with the R modifications words, like scared, she writes SCUD, S-K-U-D. Commonly used words that she would see all the time, some of. She spells phonetically when that's not how they're spelled. And we even have it as long, and in up to grade 2, it's not a problem, but later reversals like the B and D. So when we look at that, after having been in Canada since at least grade 1, we know that this child ought to be referred. We ought to be looking at dyslexia. Now, one of the questions that I was told that some people have asked about was ADHD. And so I added to this particular slide. This is a kid, 12-year-old kid with ADHD, who was writing a letter to his teacher describing changes he wanted at school. So he writes, "Dear teacher," and it's all one sentence and no capitals. "I would like to see some changes in the school. First, better toilet paper, 2-ply extra soft, and if somebody is in a fight off school grounds, should not be suspended, and if someone is fighting someone, cannot be suspended for self-defense." So we can see that this would not necessarily be typical of a kid who has dyslexia, because even though there are spelling mistakes, sometimes he spells it correctly and other times he doesn't. His vocabulary isn't too bad. handwriting is poor. There may be other kinds of learning disabilities, especially in written expression. And we would obviously need to look at this further, but word level reading is likely just fine. We don't know from this whether it's only the ADHD, but this is the kind of thing you frequently see among kids with ADHD in terms of their impairments in writing. So just a few more questions, and then, is that when we're assessing achievement for these kids, there are certain questions that go through my head all the time that I think should go through the head of any psychologist or teacher or speech and language pathologist working with them. One is, does the student understand the instructions? And so even in a nonverbal test, and we have evidence from Cormier and others that from the WISC, that many of the so-called nonverbal tests are not nonverbal. So we have to look at that. Perhaps must the instructions be repeated slowly or with different vocabulary? So I think about something like this question, such as, what are the advantages and disadvantages of e-scooters? Heard about this one on the radio today. And the kid may not know what advantages and disadvantages mean. He may only know what are the good things and the bad things. So again, if we rephrase, we might find out more about what they know. Do they respond better when they can point, or are they given multiple choice options? Do they need a lot of reinforcement? And do they respond better in their first language? And sometimes they do. Well, you should also look for certain kinds of errors. Positive transfer. So do they use words that are similar in their first language to understand English? I know I do that in French all the time. Negative transfer. So you're applying a grammatical structure that's correct in your first language to English when that's not appropriate. So we can look for those errors and know that those are ESL errors. They're not LD kind of things, unless they go on for much too long. Errors associated with instruction that's not commonly taught in Canada. So if they could even be an immigrant from the US with English as their first language, but they don't know metric. But mathematical symbols is an area. The other thing is knowledge of symbols and metaphors. And I have some good friends for whom English is a second language. And one of them talked about kicking the bucket instead of hitting the bucket instead of kicking the bucket, for example. So, that's very hard for people where it's their second language. So when we're doing that, those are specific issues for yourself. That doesn't necessarily mean there's a learning disability. I'm nearly at the end now, but when we're looking at assessing the psychological processes and those abilities essential for thinking and reasoning that Carolyn talked about, I do want to emphasize about making sure that rapport is achieved prior to giving those formal tests. That's important for anyone, but it's especially important for these kids. And some of the things that I've seen is that when we give the IQ test first for them, that they score lower than they would if you did it on the third or fourth session. Look for difference between scores on tests with high and low verbal loading. There's no test that has no verbal loading, but there are higher and lower. Repeat or modify instructions to make sure the child understands it. Use multiple methods and sources of information. Consider some of the adaptive skills they have. That same kid who is having challenges in school is out there interpreting for their parents at the dentist and doctor. And use clinical judgment in interpreting the scores. So I'm going to conclude with going back to Abdul. So I just have the information that I presented earlier up there. But should he be referred to a psychologist? And what we know from what I talked about is, yes, he should. He ought to have made much more progress in learning to read. And in fact, his profile suggests that there could be very severe dyslexia here. Teachers might try to map out what he knows and doesn't know in terms of English and math. That would be really helpful. And in terms of communicating with his mother, She was very willing and very much wanting to be involved. But one needed both an interpreter, but also a lot of reframing and putting things in simpler language. And the interpreter was helpful with that because she could assess the mother's language, which we, of course, couldn't. So, so what happened with Abdul? His achievement in reading and writing was less than the first percentile. So just knowing that's not enough, you're having to go well beyond the scores to look at what he can and can't do. Math was at the 5th to 10th percentile, depending on what test you gave. His scores on verbal part of IQ tests and were ranged between the 2nd and 5th percentile, very low, as was phonological processing, and verbal memory was less than the 1st percentile. Not a big surprise when you look at his progress in reading. But his scores on nonverbal tests of thinking, reasoning, and memory range from the 10th to 40th percentile, depending on what you gave him. So again, we know that we have a kid with average ability, but if we just had given him a whisk and looked at that full-scale core, it would have been down in the basement. So we gave an LD diagnosis and recommended an intensive support program. He did make some progress with explicit individual instruction and phonemic awareness and basic sound symbol correspondence, but it wasn't very good because his phonological processing and verbal memory was so low. So we had to do a lot of drill and practice of common functional sight words, and he learned some sight vocabulary there. But at this point, he was already in grade 6. And so text-to-speech assistive technology became very important for him and the learning of functional math skills. So if you'd like to learn more, and especially if you're a psychologist, I am inviting you to buy our book. It's not because I make lots of money off it, but people do tell me that it's very helpful. And I'm going to now just thank you, both Carolyn and I thank you. And we will both respond to any questions you might have.
Great. Well, thank you so much for that to both of you. And I'll let Alicia pull out some questions that have come in.
Thank you. Yes, we have a number of questions that have come in from live questions, and then we had people submit questions ahead of time. So starting at the beginning, you spoke about PPM8 and the need for school boards to do early and ongoing identification. Mm-hmm. And then you clarified that there is a difference between identification and diagnosis. Yes. And we just had a question if you could speak a little bit more in depth about what you mean about the difference between identification and diagnosis.
Okay.
If you could clarify.
No problem at all. So I mentioned exclusionary characteristics. So we have often seen reports where the child has perhaps a history of trauma, and the psychologist is particularly reluctant to diagnose. However, the elements of that are required in PPM8, I didn't speak a lot about, but they do involve average cognitive ability, processing difficulties, and the academic weakness. So if those three are there, and if an identification would be helpful to that student, because that student shows an academic need, then identification can take place. Of course, that depends on the discussion at the IPRC, which of course includes the parents. So it's a discussion about whether identification would be helpful in that case. It fits, it can happen, but there is no diagnosis. So that's one example. Another example may be in the area of intellectual disabilities, where a child has a diagnosis of, well, they don't have a diagnosis. They're around the 5th percentile. In some boards, and for a diagnosis of the mild level of intellectual impairment, it's at the 2nd percentile. But in some boards whose identification criteria go higher than that, if that program fits for that student and everybody's on board with that, an identification could be made. So the program offered if the parent wants it. If not, identification doesn't have to take place, Identification doesn't have to take place in many situations, but it's offered because there's an educational need and it fits the criteria of the board. Now, what's confusing to parents and to all of us is that different boards have interpreted the ministry guidelines in different ways, so that sometimes it'll go up to the 6th percentile, sometimes it matches, the identification matches with the diagnostic criteria, even though the terminology is different. Mild intellectual impairment as an identification is different than the mild range of intellectual disability.
So when we're looking, I just want to kind of chime in here because, yeah, so basically identification is a school system kind of process, and diagnosis is both from the medical field, and psychologists also give a diagnosis. So in some boards where there's no psychologist, one can still identify as a child as exceptional. Now, one also can provide special ed without identification. The advantage for parents of an identification, though, is that they then have rights. And they can come and go to an IPRC and really have an influence on the process. And that's the advantage of it. So I did want to add that.
Okay, thank you.
Clarify that. So does it require the processing deficits is a part of the identification?
Yes, it is.
And
Having a processing. Oh, I'm sorry. In terms of the identification, yes, it is in terms of PPM-8, so that it didn't used to when the criteria were developed back in the 80s, but now PPM-8 demands, those 3 elements that I mentioned.
So who can
that's an interesting issue, because DSM-5 doesn't require that a psychologist stipulate the processing deficits, but the Ministry of Education document in Ontario is asking for it, which is one other part of our impetus in the guidelines to include that. And to be honest, it's very rare that when a child has well below average academic achievement, that there isn't a processing deficit that's there.
But the identification
that one causes the other, except for dyslexia, where phonological processing deficits and dyslexia, there's actually been established a causal link. In other areas, we don't know about the causal link, but typically there is one there. So it allows for that, not only the diagnosis, but also for the identification according to our ministry criteria, which was not necessarily developed by psychologists.
And well,
although they had input.
They had input, yes. But if I can just add that also colleges and universities, I started mentioning the Human Rights Code. It requires a disability diagnosis and documentation of that, and that disability comes through the processing and through the diagnosis.
But only a psychologist can diagnose processing deficits for the identification process, or can that be done by teacher, educator?
Jill, do you mean? I mean,
well,
they could be observed by others for sure. But your question is, they could only identify it.
Who identifies?
For example, with phonological processing deficits, which is most typical to dyslexia, teachers can do that particular assessment. So in that one area,
of course,
those are not restricted tests in any way.
Yeah.
You know, the problem with the processing area of memory, for example, is that there are many kinds of memory.
Yes.
And that's not easily observed. You know, some long-term memory, short-term memory, episodic memory, working memory, all those things. It's good to have a psychologist to tease those out. But certainly for a knowledgeable person, knowledgeable teacher, for sure, yes, they could certainly identify those, or not formally identify, you know, but observe those kinds of things and comment on them and work with that idea.
Okay, and sort of a follow-up to this, talking about that formal diagnosis that a psychologist can do, what is the earliest age that you are doing formal diagnoses?
Okay, I'll talk a bit to that, because it depends where you are. And we actually have our second FAQ addresses that. typically, let's remember, diagnosis can occur of certain disorders can occur at a very young age. So you can be diagnosing autism spectrum disorders at the age of 2 even. Okay, so
Even
and
younger, 18
even
months
younger,
now.
18
Yeah,
months.
yeah.
So it doesn't mean that a psychologist shouldn't be involved at a very young age, because when a child isn't progressing in preschool, we don't know what the reasons are. Similarly with an intellectual disability, which can be severe, and we want to start earlier. When you're talking about kind of dyslexia, and I'm thinking about this particular organization we're presenting to, obviously some formal reading instruction is necessary before you know that the child isn't making progress in reading. But and it used to be said that, or there was this sort of myth going around, and some school boards followed it, that you shouldn't do an assessment till the kid was at least 8. There's no evidence in favor of that. And I'm saying that, and at the OISE clinic, we were getting a pile of kids at the end of grade 1 being referred to us because the school boards weren't assessing. And so we've really clarified that in our guidelines to say that once we've started to provide, formal reading instruction, if the child isn't responding. And I've been a school psychologist for, I started before probably most of our observers were born. But I can say that good teachers would say, and January, he's really like at October of grade 1 and it's now January. They can already see that the progress isn't being made in that kind of decoding. I'm not saying that in a January of grade 1 you should be making a referral, but certainly by the end of grade 1 we can be referring and assessing and diagnosing a learning disability. But what we do want to see is that the child has had good instruction first, and that's part of the problem.
So if I can just add, I think that we often think of the word, when can they be assessed? Assessment can be done at any time. Assessment means gathering information, and that can happen at any time. The question is about, how useful all the information is useful. Formal diagnosis might not be made until academics are taught, because you need the academic weakness. So, but certainly at-risk issues, pointing out processing difficulties, beginning instruction and addressing these issues makes a lot of sense.
And we should be doing assessment, and by that I don't mean psychological assessment and diagnosis, but early identification and assessment in kindergarten, in my view, ought to be universal, and it is in some places. So we know, for example, that a child that doesn't know how to recognize all of the letters of the alphabet by the end of kindergarten is at significant risk, assuming they've been to school and been taught that. And it's a very powerful indicator.
Yes, speaking to that, could you give an idea for the kindergarten teachers that are out there, some quick assessments that they should be doing with their kindergarten students?
Well, the DIBELS is very helpful. That's the Diagnostic Indicators of Basic Early Learning. I think skills, and it ends in skills. That's right. And so there's the DIBELS. There's even just looking at how kids rhyme. Do they rhyme? Do they play with sounds? How is their oral language? Are they sequencing properly? And of course, when they're a bit older, how if they retain information about words and how words look.
And so I just wanted to add that the DIBELS, the link is on our handouts. So
it is. It's a very useful thing.
So that would be a very easy thing, and it's free of charge.
Yes, it is. It's online. You can get that online. Listening to the children read aloud, well, except you're talking about kindergarten kids. But just referring to that other question about early grades, listening to them read aloud. Do you remember we used to do Pig Latin? I don't know how many of you remember that, but that was playing with sounds. And I hear some laughter. Taking the first sound off, putting it at the end and adding AY. That was, an indicator. All those kinds of things. Teachers can observe would be helpful.
That's great. And we had quite a number of questions in our questions that were submitted ahead of time, and then we received it again in the live questions. speaking about and asking questions about the use of the term dyslexia, which I know you touched on at the beginning for sure. But the question that came in is, why not include the term the way that it is included in the DSM simply as an alternate term?
Dyslexia is not a term used in the
it's
DSM
not
at
in
all.
No, it's not.
Dyslexia
It is actually listed as an alternate term in the DSM.
It is
In the DSM,
it is
mentioned in brackets as an alternate term,
That's
the
right.
common term.
alternate term. I mean, yes, we could include it. I don't think there's any reason that could not be included. It could be included. I think people are often reluctant because they're so used to using the term learning disabilities, and they, you know, and it's important. And also sometimes children have mixed, they have some features of dyslexia, but they have features of different reading difficulty, the more orthographic. And so they may be, or the comprehension type, they may be reluctant for that reason.
I'd like to use, I occasionally will use the word dyslexia when, in fact, that's all it is. But we have to remember that the term learning disabilities came into fore in 1963 with Sam Kirk mentioning that term. I mean, I studied with William Cruikshank, one of the granddaddies in the field. So you know, the word learning disabilities is, for many people, it explains it more. Now, the other issue with dyslexia is many people think it means mirror, seeing things in mirror image.
That's right.
And so they have the wrong idea as to what it means, and don't quite understand that the real basis of it is phonological processing. You're also then saying, diagnosing the kid with, sometimes with dyslexia, dysgraphia, dyscalculia, and so on. And whereas one term, learning disabilities, encompasses it all. And for parents who aren't quite as educated in it, having all of those foreign terms could really be devastating. So one has to use judgment as to whether to use the word dyslexia or not. And sometimes I do. So when a parent comes and asks me if a child has dyslexia, and they do, then I'll use it in the report.
And hopefully that happens. The other comment I would like to make is that rather than just saying dyslexia, we demonstrate the particular problems in phonological awareness and so forth that the student has. So we describe it. We describe it as a subtype of a learning disability, and we also state that it affects reading. And this is the processing difficulty. I understand that the term dyslexia might be helpful in finding resources online, you know, and finding finding resources. And certainly one would hope that the psychologist would recommend those places.
Okay, thank you for addressing that. Another question that we have, I think, do we have time for one more question, Jill?
Yes, we have it's about 8 minutes to 9, so sure.
Okay, great. So another question that we have is, how do we ensure that a diagnosis translates to support via an IEP and then directly into the classroom? So how do we support teachers to understand the assessment and diagnosis and then ensure that the children are getting the support they need?
Well, I can't speak for every board in Ontario, but generally it's important that psychologists provide feedback to the entire team after they've provided feedback to the parents.
So the school team, the teacher, the principal, and so on, as well as to the parents.
That's very
important.
I
think that's important. The other part is, of course, one of really good teacher training so that teachers are able to implement this. I'm going to say something controversial here, which is that there is still a view among some people in the literacy field, I'm not talking about dyslexia field, that one should not teach phonics, one should not teach all that kind of word level reading explicitly. And many teachers are taught that. and that they should not do that. Some who are more critical thinkers and read the research and so on know differently, but they're not necessarily provided with the resources to do that. And so I think that now I'm not blaming the Ministry of Education right now, because they're in fact funding rollouts of programs such as Empower, which is a very explicit and evidence-based program that Maureen Levitt and her team at SICKIDS developed. But some of the boards aren't buying into it and others are. And so I think it certainly behooves the community out there to really work with that, to try to, and here at OISE it's part of the problem, except for one of our programs where we have very good literacy instruction for teachers and training, but it is part of our job to teach them how to teach reading better. And I think these webinars are one way of getting that across.
And I think that's a great comment, Judy, about these webinars are really helpful. As you know, Jill, in my board, we watch these webinars and discuss them, and we invite special ed, and it's a very nice grouping and a nice way to get information. So we thank you so much for these.
Well, you're welcome. That's a great place to end. That shout out. Yes, well, thank you. Thank you for all the work you've done in preparing that presentation and for your time tonight. And we really appreciate having you help us understand better these new guidelines.
Pleasure.
Thank you so much.